So this is a basic introduction to identifying opioid withdrawal and kind of what to do after that. My name is Leland Sommer. I'm a nurse practitioner with the provincial program aligned with stewardship and clinical appropriateness, and more specifically with the Opioid Stewardship program. I am based out of Regina. So with this basic introduction, look at kind of the opioid epidemiology nationally and then in this province, what's kind of going on. Identify who may be at risk for opioid withdrawal, and then opioid withdrawal monitoring and the treatment of symptoms of that opioid withdrawal. Topics such as appropriate opioid use, when to use naloxone, and treatment of opioid use disorder are not covered in this presentation, but may be touched on. The main piece within the vision, mission, and values and philosophy of care that I'm focusing on is safety. And this is safety of elders and safety of the care team. And I am presenting from Treaty 4. I note that the land acknowledgement was done at the start of the meeting. I do want to carry forward a message from Melissa and Kristen. They're saying thank you for all of the engagement and the questions that came from the group from last month's presentation. From that, they are actually planning a more in-depth education session. If you're interested in that, please share with them through the email. And that's regarding the penicillin allergy delabeling tool. It sounds like there was lots of great conversation, and they set the bar high, so I'm a bit nervous today. So in when we look at Canada, 1 in 8 people were prescribed opioids, and this is from the CIHI data 2018, and this includes Saskatchewan specifically. We have a good prescription review monitoring program. So if you extrapolate the 1 in 8, that's about 140,000 people in this province had an active opioid prescription. Of those, 1 in 5 had a long-term, long basis term opioid prescription. That would extrapolate to about 30,000 people. So I'm just trying to kind of set the picture that opioids are all over this province, every care setting, and why we kind of need to know what we're looking for with opioid withdrawal and why. And then looking at the harms, we have about 21.6 per 100,000 population admissions to hospital around opioids. So the admitting diagnosis was around something related to those opioids. If we specifically look at, and this is a slide that's recent data from the end of February, we look at the graph on the left. From 2016 to 2023, we can look at the confirmed drug toxicity deaths related to opioids. 2022, they have not all been confirmed, but the key takeaway on this one is that in the first quarter of 2023, we've already had about as many suspected opioid drug toxicity deaths as we did in the whole year of 2016 or the whole year of 2017. So we are not immune in this province, and the drug supply has changed. So when we look at the image on the right, this is looking at what street drugs or illicit drugs were associated with those drug toxicity deaths. And you can see that it's very much changed over time. So if you read each bar, so if we look at fentanyl at the top, it actually goes from left to right from the years. And we can see that fentanyl is becoming more prominent as we move through the years, but we also have more types of fentanyl in the system, which are more potent and more toxic. So we have the fentanyl, we have the acetyl fentanyl, fluorofentanyl, and they are becoming more potent and creating more opioid related toxicity deaths. Another piece I just wanted to touch on going from that is a lot of conversation happens around opioid potency. So I'm looking at prescribed opioids, and when we look at this, when somebody says there's a conversion, the morphine is always on the left. Morphine is 1-to-1. That's a gold standard. The other agent is on the right of the colon. So the biggest takeaway is less potent does not mean it's safer. So oxycodone is a little more potent than morphine, but not much. Tramadol is less potent. Codeine is much more less potent. Oxycodone has a high risk of addictive properties. Tramadol has risks for decreasing seizure threshold more than many other opioids. And codeine has a very unpredictable metabolism, and that can be related to a genetic predisposition of CYP2D6 deficiency. So just the way it's processed through the liver. So, but we also can see fentanyl. So if we do the conversion there, it takes 100 milligrams of morphine approximately to equal 1 milligram of fentanyl. So you can see that the potency of that fentanyl is much higher than the morphine. So who may require monitoring for opioid withdrawal? And this list may not be who you expected. Those with chronic pain, those on long-term opioid use with a dose change. We have seen this within the service we're trying to get started and to expand provincially for pain service in the hospitals, is that if there's a dose change or missed doses for somebody that's been on an opioid for a long period of time, we are often seeing early signs of opioid withdrawal. If there's been an opioid rotation, so say a rotation from high dose morphine to hydromorphone, sometimes people process differently and we can undershoot and they can start going into an early opioid withdrawal. Cocaine use, why that's on this list is fentanyl or any one of its derivatives are in the drug supply across this province. So we have seen examples where somebody says, I've never used fentanyl. We're giving them exorbitant amounts of opioids and cannot meet their pain management needs. And then we go down the path of other drugs they may use. Well, I use cocaine every couple weekends just recreationally. The cocaine has been tainted with fentanyl, so their opioid receptors are impacted because of their exposure to fentanyl. Known opioid use disorder, those dependent on opioids that suddenly reduce or stop taking their opioids, that is a big part of who we see with the opioid use disorder. Post-operative comorbid with any of the above, because they've likely had a gap in receiving an opioid or matching the opioids that they may take illicitly out in the community. And then precipitated withdrawal. So with precipitated withdrawal, I just wanted to do a myth buster here. So if we start Suboxone on somebody, there's a common myth that it's the naloxone within the Suboxone medication. It's a combination of the buprenorphine and the naloxone. There's a common misperception that the naloxone is what's precipitating that withdrawal. It is not the naloxone. The naloxone cannot act within the GI system when it's taken orally. That naloxone is only activated if the tablets are tampered with and somebody tries to use that tampered medication intravenously. It is actually the buprenorphine, and buprenorphine is a strong partial mu agonist. So if somebody has recently taken an opioid, a full agonist opioid, something like morphine or fentanyl or methadone, and they take the Suboxone with the buprenorphine in it, the buprenorphine is very strong and it's a partial agonist. It actually very quickly replaces the other opioid before it is up to levels to fully replace. So it's knocking off the other opioids and precipitating those withdrawal effects, okay? There are strategies that we can implement with harm reduction and opioid OSIS, our opioid resource for starting opioid agonist therapy, that reduce those risks. And it's usually a slow introduction, but I just wanted to bust that myth. We can also precipitate withdrawal by giving Narcan on the floor if we suspect an opioid overdose. So that's when we're going to see that very rapid onset of opioid withdrawal. So what is happening when we're seeing the opioid withdrawal? So this is occurring at the brainstem, and that is an important piece to understand. Within the brainstem, in the locus coeruleus region, is the main source of noradrenergic neurons. In the brainstem, though, when something's happening there, it doesn't go through the frontal cortex. There is no impulse control, and if something is really activating the noradrenergic system, the person experiencing those symptoms has no control over that. They are seeing this as a risk to their well-being. Okay, so it activates that fight and flight response, and that is many of the symptoms we're seeing. And also in this locus coeruleus region are an increased number of opioid receptors. So when those opioid receptors are not populated by opioids, then you have the activation of the noradrenergic system and those opioid withdrawal symptoms. So I just wanted to briefly introduce, this is the monitoring that many people are familiar with for alcohol withdrawal. We're going to come back to this. Some of the things we monitor for on the CWA are similar, but not the same for monitoring of opioid withdrawal. But it's just, it isn't new. There isn't a lot of new information. It's just introducing what may we use for monitoring of opioid withdrawal. So for opioid withdrawal, we have two options currently in the province. One of those is the clinical opioid withdrawal scale, and the other is the opioid withdrawal scale. They're very similar. There is work currently happening in the province within the provincial order sets to introduce a common approach. So I did look through kind of where I could access and any pre-printed orders, any resources, and these were the two that I found across the province. If we look at the orange ones, that is specific to the cows. The green one, they talk about change in temperature. It can be similar, but just asked in a different way than on the cows. The cows is what is referred to more in the national literature around opioid withdrawal. So, and when we talk about starting out, the cows is typically what is referred to. Now it is more clinically accepted across the nation. As the projects move through their process, then that committee will have to decide which monitoring system will be chosen. I just wanted to introduce both here. Pupils, what you'll see typically with an opioid withdrawal, so opioid overdose, we're seeing those very small constricted pupils. When we look at withdrawal, we're seeing those really big pupils because that person is getting ready for fight or flight. Okay. We also monitor things like diaphoresis, lacrimation, rhinorrhea, the diarrhea, the stomach upset, the yawning. And the people are going, well, I'm not having diarrhea when I'm running from a bear. Why is that happening? This is the rebound or the overcorrection of the autonomic functions at the brainstem. So that whole system is just in overdrive, and that's where those symptoms come from. Something like yawning, an uncontrolled, very repetitive yawn, is a pretty specific symptom with that opioid withdrawal in the early stages. Just if you're doing the opioid withdrawal scales, either one, the higher the score, the deeper you are into that withdrawal and the more symptomatic the person is. And they can objectively be used to make treatment decisions with the care team. And then I said we come back to the alcohol withdrawal. So I just wanted to show again, just there are similarities. The ones with the asterisks under opioid withdrawal are more specific to the opioid withdrawal scales. But it's not new things. They're very similar but different. So it's just using the appropriate scale to monitor that opioid withdrawal. So now what? If I've identified somebody in mild, moderate, or severe opioid withdrawal, we seem to be more comfortable with the alcohol withdrawal, and with alcohol withdrawal, we reach for benzodiazepines. With opioid withdrawal, our first response as a team is we don't want to be reaching for those benzodiazepines right off the hop. So I'm just going to briefly go through some options for those symptoms that you may be seeing. But why we don't go for the benzodiazepines is the opioid and the benzo are both central nervous system depressants. And if that person chooses to reach out and use an opioid illicitly, and you've thrown some Valium into the mix, and they overdose, you could have a very, very hard time reversing that overdose. So it's a safety piece. So symptom management, so the restlessness, the tachycardia, and the diaphoresis, what I've taken is kind of what is used. I looked again across the province. I think I looked at Sunrise, former Cypress, Regina, Saskatoon is the ones I could get into and find some PPOs. And everything was a little bit different, but there was some commonality. So I've just tried to summarize that here. The restlessness, the tachycardia, and the diaphoresis. Clonidine is kind of what is on the Regina pre-printed orders. It is in Saskatoon and Cypress within the detox orders, but it is definitely a really good medication with the BP parameters and the heart rate parameters to make sure it's safe to decrease some of these symptoms. And why it is a key one is that it actually works right kind of at that brainstem. It's an alpha-2 adrenergic agonist, so it's directly treating that fight-flight response. The anxiety, irritability, lacrimation, all of those other rebound symptoms, hydroxyzine works well, and it actually has a sedative effect, which can help also. The insomnia, trazodone is an option. Myalgias, the basic acetaminophen, indomethacin, naproxen, ibuprofen all work really well for those muscle aches, those joint aches. And why that's happening is that fight or flight, and they're just in that ready to pounce mode, and the muscles start to fatigue. Okay. Spasticity, restlessness, baclofen is also an option. The diarrhea, loperamide, hydration is key. Nausea and vomiting, the dimenhydrinate, Gravol, hydration are key also. So it is, there are some basic things that work really well. Here's some of my references. And I just wanted to end with, I hope this helped just as a basic introduction. There's lots of work happening around the province. Why I thought this would be important is many on this call maybe reached out to give their feedback on the PPOs or the clinical standards. And it's really about the safety of the patient and the safety of the care team. Because if we don't identify this, we can be putting the care team at risk. Any questions?